So yeah, the reason we're talking.
Yeah, one of them.
Yeah, well, the reason we're talking today right now. I had this idea. There's so many people out there with mental health issues that are completely not talked about, oftentimes not admitted even to themselves. If they are admitted, not admitted publicly, not discussed publicly. And since I've been going through my own issues with depression and anxiety for many years, and we've been friends for a while, and
Yeah,
you've got your background in psychology. As a clinical psychologist, I thought, hey, shit, man, this could be the best thing we can talk about.
it is something that I like to talk about, actually. Yeah, it's, I guess also people with mental illnesses, um, it's really hard to get good information because the problem with reading about it is you kind of start to, after a while, you go through like a confirmation bias loop, I guess, where you just see all these
You mean
sort of
if you read
symptoms.
about it to try to improve yourself and to help yourself,
No,
or
I
in
mean
general, just
just to,
reading about to inform yourself?
yeah,
Mm-hmm.
exactly. And you kind of start to look like, oh, that happens to me and that happens to
Oh
me.
yeah,
And that's what I mean, like this confirmation bias loop. If you're not quite sure what's going on, you might think it could be any number of things because there's so many overlap
yeah,
between symptoms and things like
yeah.
that.
And you might accommodate your self image or self perception to fit what you identify in
Exactly.
the same way you would do, I don't know, with your zodiac sign or with the side effects from your prescription.
Yeah,
You know?
exactly.
Yeah.
So yeah, and I guess the as you mentioned before, it's not spoken of
Yeah.
nearly enough, and of course there's still the stigma, but I also think it's maybe not understanding really because if you are going through it from a subjective point of view, um, yeah, it's tough enough to kind of try to piece together why do you feel this way, and that's hard enough without having to think, oh, what am I actually going through? What is this called? How do I explain this?
Yeah, for sure. And also in Western society, being a rather individualistic society,
The
it's
most,
yeah, yeah, exactly. So rather would be a euphemism, but yeah, indeed, the most individualistic society, um, the the impulse tends to be to just carry it within you and not share it, also for a reason of intimacy, and also trying not to subject others to your um, uh, impulses that may be
right?
caused by what you're going through. So there's a lot of repression in that sense.
Yeah, and of course serving the social function because yeah, you find people when you talk about your mental struggles, a lot of people don't know how to react. They either try to distance themselves from you, and if you're already feeling depressed
Yeah,
or,
that's
or
the
lonely,
fear.
yeah, exactly, you could become even more isolated. Or people go the extreme and kind of want to try to fix you in a way.
Yeah,
And that's also not really good if you start off a relationship on that kind of footing, I would say.
yeah, for sure. Or just having a very exacerbated view of what it may be like to be struggling with a mental health issue. Wow, mental health issues vary broadly
Yeah,
um, in terms of effects and experiences, but there is a bit maybe the image of the loony or or something that um,
there's someone who's completely lost touch with reality
yeah,
in a way.
yeah, yeah, because well, in the past, these these issues weren't addressed as they are today, and there weren't many means available for people to seek help. Uh, neither. I don't know about psychology. When did it start becoming a widespread practice,
I would,
like counseling?
well, counseling, it depends what you mean by counseling, because I reckon it's been a widespread practice since shamanism.
Right.
And I feel like the intellectual tradition, it's not a straight line, but the intellectual tradition of the psychologist as we know it from 20th century, late 19th, early 20th century. We go back to William James and Freud. I believe that the intellectual tradition of looking in the unconscious for uh, symbology and emotional baggage, for want of a better
Mm-hmm.
word, a sort of repository of anything and everything that's ever happened to us and the emotional states that we associate with them. Yeah, I think that goes back to shamanism. And the shaman would journey to the spirit realm in a variety of ways, plant substances or rhythmic dancing, starvation, dehydration, etc. And yeah, come back with an interpretation of these unconscious feelings and symbols and whatever you want to call them, this nebulous thing that sort of lurks under the surface of our conscious mind, and then explain this to the tribe or to the person, and that would kind of open up the path to healing. So yeah, I would say that's really where it started.
Yeah.
But if you want to talk about talk therapy as we know it today, I guess, I mean, Freud is pretty much the obvious place to start. I mean, there was people like William James doing similar things, um, but I might have the timeline slightly messed up. And there were also, of course, doctors looking into the brain as an organ and studying neurology. But the talk therapy thing, I guess, was popularized by the psychoanalysts Freud, Jung. And yeah, that's where I kind of look in some ways for guidance, but not always. I think we've evolved a lot in terms of our understanding of behavior since then, and pathology as well.
Yeah, it's interesting because in the end, I guess it became widely available together with public health care,
Yeah,
which only really took off in the past after Second World War, roughly speaking. Um, so yeah, that's interesting because the means to treat um, the psyche and the brain have taken off at the same time with the means to widely treat infections or
right.
other other health problems. Yet these ones we don't talk about. For example, when we talk about antidepressants, taking antidepressants, I find so much reluctance out there and a a view as if um, they are this crutch that you shouldn't take the chemicals to make yourself feel better or something in that direction. And it's really strange to me because there is almost like a value judgment attached to this. And when in fact it is just a engineering engineering output, a chemical engineering
Yeah,
output that our society created that can help you. Nobody says, "Oh, really? You're gonna wear glasses? You're gonna wear glasses to see better.
yeah.
You
It's
don't wanna
interesting that
you
you.
don't wanna face the world on your own term with your own strengths and weaknesses. You don't want to face it like that. You're gonna take a crutch and see better.
Oh yeah, I mean,
Nobody views this piece of technology in this way, but antidepressants certainly are viewed, and it's a bit strange to me. Maybe I view it in this way.
no, I think a lot of people do as well. a lot of people are reluctant to the idea for a lot of other reasons too. I guess also, though, on the flip side, some people also take it as something that they take and therefore don't have to deal with their actual problems.
Like a cop out.
Exactly.
Yeah.
So I guess, I mean, there's all sorts of perceptions about them in society. Personally speaking, like from a treatment point of view, I would prefer a conservative approach to antidepressants. If I saw a patient, let's say, and it seemed like in the first session that there was some signs of depression, I would do a risk assessment, see how is this person a danger to themselves or to other people, and if they're not, but they're kind of getting by, I would just discuss with them, look, I think we should give the talk therapy a chance for a few sessions and see how far we get. Generally speaking, if you're going to see any improvement, probably after 3 to 6 sessions, you start to feel a bit better. Depending, I mean, obviously on what's gone on with you and the relationship between you and the therapist. That's very important. Then I would reassess and say, okay, we've had these sessions. Do we still think medication is necessary or not? And if we think it is, then I'll do the referral. But sometimes from the beginning, I think it's maybe a good deal to start off with the medication. Or even, I mean, sometimes people are acutely in crisis and might need to even be hospitalized, just as a precaution. Of course, that's an extreme situation. But yeah, that's the type of approach I take to antidepressants. And I feel like it has to happen in conjunction with therapy. That's the most efficacious way of using them.
For sure.
And yeah, I don't understand how they work. I understand they're selective serotonin reuptake inhibitors, so they act on the serotonin system, but there is conflicting evidence as to whether that is their actual mechanism for curing depression or it's something else, because serotonin is not, it's more of a neuromodulator than it is a neurotransmitter too, but that its function is to kind of modulate the levels of other neurotransmitters too. And so it could be that an increase in serotonin has another effect on another part that we can study, because antidepressants are sometimes beneficial and sometimes completely wreck the person too. They have the opposite effect of what they do, so, or what they intend to do, let's say. So yeah, I take a skeptical and conservative approach to referrals for antidepressants myself.
So would that be? Do you find that those cases are frequent when the antidepressants do more damage than help?
No, I wouldn't say that they're frequent. I would say that there's always a risk, and you can never know before you put the person on the medication how they're going to respond to it. So that's the thing. That's why I say in the most dire of situations is where you go for that.
Yeah, yeah, and I agree with you. Probably, almost certainly, most people don't need antidepressants. It's really a minority of people.
But yet the US, a lot of people are on them. I mean, it's a staggering number.
Yeah, well, US is known for overprescribing
Yeah.
everything.
They like their drugs, just not the fun ones.
Yeah, exactly.
Yeah.
So, but yeah, for sure, the most people don't need antidepressants. But the way my impression is, having been in contact with the field as a recipient of treatment, and also as being just curious myself and trying to understand better depression mainly. Um, it it definitely seems to me like talk therapy is the first angle to address it.
Mm-hmm.
And from what I understood, at least here in the Netherlands, they only prescribe antidepressants for people with major depression and repeated episodes of intense depression.
Okay.
And there's a grid, how many they call them episodes, yeah, of intense depression you had. And if you had if you're at your second one, then they try for 1 or 2 years to give you. And if you're at your third one, then it's 5 years, and so on.
That you have to take medication for.
Yeah, of course, if you want.
Right.
It's never.
It's a long time.
Yeah.
5 years to be on that drug is
Yeah.
a long time.
But it might stabilize you. It might work for you if you're also trying to improve the areas where you feel you have issues. So not just the intensity of your feelings, which is basically what it really does, preventing you from falling into extreme emotions or extreme feelings or anxiety. So yeah, that basically gives you like an armor, like a mental armor to cope with your issues. And in that state, you should address them through talk therapy or self-help if you're really good at it.
Yeah, so you've had a few sessions then, right? Therapy sessions.
Yeah.
What is it about the talk therapy for you that you feel is beneficial?
So it actually helps me organize some thoughts. So finally, I didn't always treat therapy in this way. Many times I treated quite ad hoc, like just something that I ended up doing because I wasn't really feeling well in general, and I just thought, yeah, this is what you do when you feel like this. So I've tried it many times, but now I think I managed to get closer to having a dedicated space to touch base with my fundamental honest reality and work with those parameters. Yeah, analyze them, try to move some pieces, try to listen to yourself better, because of otherwise finding myself well, in the rat race, just caught up.
So in a way, just having that time and a focus of dedicating this time and this space
Yeah.
to thinking and being open about what's going on with yourself.
Yeah.
That in itself is curative to you in some way.
Yes, for sure. It because a lot of depression, in my experience, is being stuck in a rut, and for a lot of the time, not feeling like you're moving anywhere, you're getting anywhere. That's being stuck.
Yeah.
What it is.
Stuckness is a very common experience, actually,
Yeah.
when people come to therapy. Yeah.
And it can last. Sometimes it can be in a rut for weeks, or even a different or months, or even a different level rut for years.
Yeah.
You only discover these in hindsight, really. Yeah. Oftentimes you don't even know that you're dysfunctional on some level.
You're kind of not functioning optimally, but you're getting by in a sense, but with a feeling of something hanging over you.
Yeah.
Like, oh, hello. Like there should be some kind of journey or some kind of destination, but you seem to just get, like, stuck is a good metaphor.
Yeah.
You're just moving in the one spot and trudging along, but this projected destination never seems to arrive.
Yeah, exactly. That's a very good way to put it. So by seeing a therapist and regularly touching base with myself with the help of the therapist, I feel like I'm more on a track than I would feel otherwise. Yeah. And seamlessly pieces are moving and improvements are taking place. Not always fully fully consciously. Like I can't always track that a therapy session has influenced me into making changes, but in therapy I can track the changes that have happened and yeah,
Right, okay.
work with it in that way.
Um, do you know your therapist's particular technique of working?
Trying CBT now,
CBT? Okay.
yeah. Um, but oftentimes I really use my session just talking about recent events and developments, and that that's what I find helpful. The CBT part sometimes I can't I can't really get over experiencing it as a bit prescriptive.
Mm-hmm.
Yeah, it's not something I respond to so well.
Yeah. I mean, I have a similar frustration with the paradigm, in that at times it can feel prescriptive. And I think CBT is, I mean, it's very, very valuable for many, many people, don't get me wrong, but you need to be the type of person who responds to it, first of all, and you need to have a very competent therapist, because the problem with CBT is that um, oftentimes it gives the therapist something to hide behind. And it's like you could say, "Oh, I need you to do these exercises, and
Mm-hmm.
I'm gonna I'm gonna ask you these kind of questions, and then we're gonna see what comes up." And it's very much a structured thing. And so if your therapist always tries to impose a structure on the session without actually giving the person the space, like you say, that is pretty much the thing that you go there for.
Yeah.
I feel like people will drop out of CBT. But I like to, for certain things, because CBT provides a framework to alleviate a problem directly without a lot of other conversations around conversations and deeper things that do take place. I will say, all right, we're going to try something a bit different. I want to do an exercise from here because I think this might help you with your anxiety. I actually really like CBT for anxiety. I think that it's a very good tool for anxiety, but I don't go to it for other problems, especially um, things that have a lot more to do with personality issues or even with depression. I find like from time to time, yes, behavioral aspects do show improvement in the patient, but the the way I think about depression is about finding meaning, and I think that that's
Yeah.
not something that CBT really addresses as a philosophy.
For sure. Because yeah, indeed, someone who's been stuck in a rut for a long time, uh, the rut is there because of a lack of meaning,
Yeah,
um, and through some and someone who is stuck in a rut also doesn't really is not on the frequency on which they can truly help themselves as much in this fashion, in this structured, organized fashion. They are fundamentally mm, maybe lost is not the right word, but disoriented, and it requires one to be at least grounded enough to be able to apply yourself the CBT techniques in a with some degree of positive energy
yeah,
that also creates the expectation of improvement. But if you're depressed, you're actually not, you're quite even skeptical of your own improvement.
right.
Yeah.
And actually, you bring this up, but so I did say that, especially the behavioral side of things, I like to address in the therapy when we do depression or therapy for depression, because I don't know if you've heard of this psychological study. It's pretty weird, but they did an examination of people holding a pen between their lips
Mm-hmm.
or between their teeth like this.
Yeah.
So when you hold it between your teeth, it makes you smile.
Yeah.
And the people who are completing a test and doing certain tasks with the pencil in their mouth rate this test as more enjoyable or rate the task as
Yeah.
more enjoyable.
Yeah.
So they kind of short circuit the body because you're smiling.
Yeah.
You
For sure.
think you're happy, and there is a way through this kind of thing out of depression.
For sure.
And I like to also then tie this in with an existential point of view, which is that, like guys like Sartre would say, to be is to do,
Mm-hmm.
and to do is to be. So sometimes, if I'm in dealing with a patient who's depressed, I would often say, "But okay, what are you doing day to day? How do you do depression?" And they'll say, "Yeah, well, I my alarm goes off. I say fuck it. I kind of stay in bed for hours after that, and then I don't get up until I'm really hungry or I really need to go to the bathroom, and then they do that, and then it's kind of like, okay, where to now?" And
Yeah.
they don't really move or get anything done.
Yeah.
And I'll say, well, yeah, no wonder you're depressed, because look how you do things all day. And after some time, the whole goal is to just start increasing the person's agency incrementally. Well, maybe instead of not getting up when your alarm rings, like you do something completely different. You set your alarm for a bit later then, and the minute you get up, you just do like 20 push-ups or something.
Yeah.
You know, and slowly scale it towards more and more things. And that is the way out of doing depression, is to do something else. And I know it sounds very simple and very reductionistic, but you have to start with something that is manageable, something that also then gives the person a sense of accomplishment afterwards, and you kind of build a little cascade of wins.
Yeah, and it's a good start, because if you're in that state of mm, lifeless, inactive,
Stuckness.
stuckness, depression, then you're also probably quite neglectful of the environment around you.
Absolutely.
And that's a really good place to start, and it can easily create how did you call it, this circle of
A
wins?
cascade of wins, yeah.
Cascade of wins, because you're doing the activity of, well, sort of cleaning your room.
Right.
Jordan Peterson.
Yeah.
Yeah, you're cleaning your room. You get some sense of order in you create some sense of order in your immediate environment. You have also the feeling of accomplishment for having done something, and you leave something behind that's a reminder later, like, hey, this looks good. It looked bad before, and now it looks good. So but also it is a way to kickstart, but at least in my experience, it can also be short-lived.
Right.
Yeah.
And that's probably because the next level in the scale is either too big of a jump, or you don't really see it yet.
Yeah, you don't see it.
Yeah. And I guess at this point, probably it might be useful then to kind of broaden what you've sorted out, because once you've got a few wins in one area of your life and something is going better, you've got to start thinking about other issues, relationships, for instance. And this is then very, very, very fertile ground, I think, for exploration and therapy, because then you can kind of go back into your interpersonal relationships previously or relationships with your family, then start identifying patterns there and ways of interacting with people. Now, sometimes your therapist can do this simultaneously while helping you to cascade wins and challenging your maybe unreasonable thinking, if you want to use a CBT term, or illogical and invalid or unhelpful ways of thinking. Then also to explore your interpersonal style and how you evoke certain responses from other people with that. And yeah, of course, I reckon anytime you're doing therapy, that aspect needs to be addressed as well. Because to me, therapy happens in the relationship between the therapist and the patient. And oftentimes, what the therapist tries to do is to adopt what is known as a formless stance. So, like, I'm in a way myself in therapy, but in a way I'm not.
As the therapist.
As the therapist, I have to allow enough formlessness, in a way mystery. Like, I don't reveal too much about what I think, who I am. I let the person build up some kind of image. Then at some point we might address how they would see me or how they interact with me and say, but you seem to see me in this way, and that tells me that you need certain aspects in a relationship, or this is kind of how you interpersonally sort of try to receive nurturance, or try to engage, try to bond or connect with someone, is by seeing them in that way, and then they feed this aspect of you. And where does that come from? Where does this need come from? Where does this the Gestalt term is unfinished business. Where is this unfinished business? Why are you trying to make me into your mother or father?
Yeah.
You know?
Yeah, so from their description, you kind of make a reading into how their world is colored.
Exactly. And through the way that they interact with you, because it's, as much as I say you don't always reveal what you're feeling or what you're thinking, what your patient makes you feel in the session as the therapist is a very important clue about what's happening in the relationship. And so I don't want to act it out. You see, I don't want, like, if I'm angry, I don't want to behave as if I was angry outside of therapy. You know, like lashing out or whatever, or however you express your anger, screaming. You want to find a way to tell the patient, like, you've either disappointed me, or I've been getting quite frustrated because when you say this, or when you maybe try to discount all the work that we've done, I wonder why you feel like you need to make me feel bad, and I wonder how that plays out in other relationships with you, and where is this impulse coming from? And then we can move from there. So bringing the therapeutic relationship as a topic of discussion is a way to get a sense of other relationships too.
Okay, so if I get this right, this happens when the patient talks about you.
Sometimes, yeah, sometimes you could do like that, but they could also provoke something in you in the way they talk.
Okay.
Yeah.
I see.
Or through, the therapist Fritz Perls calls it game playing, like the verbal games that they might do. Like you often find, let's say for instance, like a patient will purposefully kind of start saying, "Oh, I don't know if I can," and I don't know what's going to happen, and they really try to make it difficult to make the connection, and then you've got to kind of now when you're telling me you don't know what to do and you don't know if things are helping, I get the feeling like you're either trying to make me come in and rescue you, give you something, or
I see.
Or you're trying to distance yourself away. Do you realize that that's maybe how others perceive you in those kind of situations, And try to broaden the insight into those interpersonal ways of doing things. So if you notice a pattern, I don't think my example was eloquent enough, but I think it made the point.
Sure. Yeah, so would you say then you you try to also make the relationship between the two of you explicit in times of need?
Yeah, I would say so.
Yeah.
I would say so. Um, and also communicate a sense of genuine caring in the relationship, because that's important. And this goes back to what I said about you don't necessarily always enact your feelings,
Yeah.
because a wise person once told me it's only therapy if they need you more than you need them. And you wouldn't want to enact your feelings, because then you could be giving into a feedback loop that you lose control over. You want to be able to bring the discussion to that level.
Yeah.
And because in that way, there's no judgment. In that
Yeah.
way, you're not, taking revenge on the person or making them feel bad about themselves. You're actually trying to identify something to be worked on, not something to judge the person or condemn them on.
So you have to be very mindful.
Exactly.
Yeah. And how do you do that during? Do you find it easy to be mindful in general?
Um, I guess so. I guess because in therapy I'm practiced in it, but it's different because I don't adopt that role anywhere else.
Yes. I see. So it's a coat that you're wearing.
In a way, yeah, it is. I mean, the thing is, it's quite annoying if you do it to people in your personal life.
Yeah. Especially if because you can see it's not genuine.
Exactly.
Yeah.
And so it's not to say that in therapy I would not enact my emotions, but in the outside world I always do. That's not really the case. But like I wouldn't have a conversation, let's say, with my wife, and then start therapizing her. She would pick it up pretty much immediately. Yeah. But I guess being mindful in therapy kind of you can start to see patterns or kind of recognize what people need from you as a friend or as a partner or whatever the case may be, in maybe a way that other people aren't always attuned to.
Yeah.
I guess that would apply.
Yeah, I see. Yeah, I wonder a little bit about your experience, because I think you had a quite different experience than most clinical psychologists in the world, because you practiced it in South Africa in quite underprivileged communities.
Yeah.
Yeah, with problems that differ greatly from the problems that we have in the West, I think, and why most people in the West seek out psychological help. So what was that like? What did you deal with the most?
Oh, that's a pretty tough one. I did several different things back home. First, I started off doing forensics. So I was assessing criminals who'd committed, they were mentally ill people who'd committed crimes. And you basically assess whether they are responsible for their crimes and fit to stand trial, or whether they were mentally ill and actually should be sent to hospital, not to prison, right?
Yeah.
And then also dealing with severe psychiatric problems, bipolar, schizophrenia, severe depression in an inpatient setting. Then I've been in clinics where people walk in from the street and there could be anything. It could be trauma, it could be depression, anxiety, personality issues. A lot of trauma in South Africa because it's a very violent place. And especially in the townships where I used to work, I used to see a lot of people with like PTSD, depression, quite a few substance problems as well. And then I also worked at a children's hospital, and that was a completely different ballgame. Also, a lot of trauma, but also then like family therapy and educational issues, ADHD a lot of the time, teenagers with emerging probably personality issues, and yeah, or any kind of thing that would go along with socioeconomic deprivation, which is a very big part of day-to-day life there. Um, and I can't imagine that there are many people still in Europe who would go through the same things to such a degree as the people in those places in South Africa. So yeah, I think it's a totally different kettle of fish for me.
Yeah, yeah. And how do you feel? So I wonder if for you having like, do you? I want to ask, do you rank these types of issues? Do you feel like it's more difficult to deal with one than with other, to treat one than other?
Yes, definitely. Definitely. There are some, I would say, presentations, clinical presentations, some diagnoses
Yeah.
that are way more difficult to work with than others. But also, it depends on the person themselves. Like some people have difficult problems, but they have positive aspects
Mm-hmm.
as well that are strengths that can be kind of catalyzed to overcome the problems. Some people have fewer resources available to them and it becomes more difficult. So back home, it really used to be kind of, I would think on Maslow's hierarchy a lot, you know,
Mm-hmm. Mm-hmm.
when someone doesn't know what they're going to eat tonight,
Yeah.
it might not be a good time to go into their childhood, you know.
Yeah.
It might be a good time to try to get immediate problems solved, you know, things that are more
Yeah.
pressing, life
Yeah.
and death. Um, I don't expect that that is the case here to a large degree. I think here people perhaps are, I don't know, what I see as the disease of our age
Yeah.
is this, you know, the depression that you described earlier is a lot of people who are high functioning people with some kind of ennui about life and sort of feeling that, like, what is it all for, really? You know,
Mm-hmm.
we've got access to the whole world. We can buy anything we want basically online. But a lot of us go about like drones the whole time and either just consume or retreat or um, try to solve things through hedonistic ways of being. And it catches up with us. None of those ways of dealing with our condition uh, get us from a stuck position to an unstuck position.
Yeah.
You know, that's how I sort of see it here. Besides, of course, the other things like schizophrenia and whatever, which are organic to a large degree. I feel like depression is our
Mm-hmm.
great spiritual war in this age.
So I'm sure we're gonna talk about depression a lot, but now that you mentioned schizophrenia, um, how prevalent is that? I think that's one of the mental issues that definitely receives a lot of stigma.
Yeah,
Yeah. Um, have you come across it a lot?
plenty, and yeah, plenty back home. Saw a lot of patients, and it's really sad. It's tough. Not many people that I saw were able to live functioning lives outside of institutions. Some were, but not too many. Um, and yeah, the prevalence of that is around 1% in the general population. So um, yeah, a big burden on the healthcare system and people's lives.
So it's a debilitating disease.
Generally speaking, yeah. I mean, look, the medication is pretty advanced, and I guess uh, the partly there. This is actually a contentious subject. So, part of the treatment for schizophrenia previously used to be institutionalization.
Mm-hmm.
Now, people are moving away from that into more of a community-based care thing and trying to get that person to function as normal life as possible. So, I think with the right resources and the right people dedicated to it, you can live a sort of okay life if you've got good treatment and you're honest about your symptoms with whoever you deal with. Because it's weird. There's always this paradox in treating people with mental illness, because on the one hand, they if you're schizophrenic, you don't necessarily always know you're sick,
Mm-hmm.
but you know when you're well.
Yeah.
But when you're well, there's something seductive about retreating into the sickness, that sometimes people will start to see signs and then go, okay, this is back now. I'm going to say something about it. Whereas other people go, this is back now. I'm not going to say anything about it.
Right.
And invariably end up regressing and relapsing, where they could have maybe dealt with it beforehand. And I don't know if it's a seductive aspect of being sick, if there's something about being in the sick role,
Mm-hmm.
or
So what do schizophrenics experience?
generally speaking, schizophrenia. There's two kinds of symptoms in schizophrenia. There's positive symptoms and negative symptoms, and it's not positive as good and
Mm-hmm.
negative as bad. It's kind of like positive symptoms are things that happen
Mm-hmm.
that are like added on to you,
Right.
right? So hearing voices is an extra stimulus,
Right.
or delusions. So people in South Africa, for some reason, everyone who became schizophrenic and was like into rap became Tupac in their mind. That was like, I met so many Tupacs in the hospitals.
Shit.
Yeah, a lot of times you meet Jesuses, but I met a lot of Tupacs.
Oh wow.
Yeah. So they might have delusions of grandeur, or like some people have delusions of persecution. They believe that someone is out to get them, someone's trying to kill them. Others have kind of a mix of a few things. Some hear voices, some don't. And then also you get the negative symptoms, which is deficiencies in normal behavior.
Mm-hmm.
So people kind of have this very flat affect, or flat emotional expression, rather.
Mm-hmm. Mm-hmm.
And their voice doesn't change tone. It will be monotonous. They kind of seem like a stone to you, in a way. And or they might get catatonia. They kind of just sit in weird positions and don't move for hours, and they're kind of there but they're not there,
Wow.
type of thing. So those are different categories of schizophrenia,
Mm-hmm.
but the disease itself, the way I see it most of the time, or the one that gets the most attention, let's say in public eye, is the kind of paranoid person who hears voices and thinks everyone's out to get him.
That's the stereotype.
That's the stereotype, but it can be a different presentation. Yeah.
And he said that most people with schizophrenia cannot really function normally, cannot really live self-sustaining lives usually.
Yeah, usually. I mean, I don't want to say most, like 90%, but probably 55 to 60%. And others with better resources, with better community care,
Mm-hmm.
can still have.
Because the symptoms keep coming back, the sickness keeps coming back, so they need help. They need someone in their lives.
Yeah, to kind of monitor and to keep them on the straight and narrow, in a way. Sometimes the medication does this very, very well. A lot of the other times, though, there is cycles. You know, people go through times where they need lower doses, higher doses,
Mm-hmm.
and yeah, it's up to you and your doctor to talk about that, and also if you're seeing a therapist, to be able to cope. And then some people then need like social workers involved. Some people need occupational therapists to come and help them in fulfilling their job requirements or things around the house. You know, so yeah, it's a multifaceted approach, and if you treat people in that way, I think they have a better chance. Unfortunately, because of the resource situation in South Africa, it would be like you're medicated until you stabilize. You maybe get some psychotherapy in the hospital. Once you're out, you go to your clinic. Maybe you see a psychologist if you're lucky, if there is one there. But you go to your clinic, get your medication, and then you're on your own. And if you start relapsing, you better not miss your appointments, because you're just going to be, you're going to relapse and be on the street with severe issues. And usually the police are the ones to bring you in. So it's tough for those people.
Do you know anything about traditional shamanistic approaches to dealing with schizophrenia?
Yeah, it's actually very interesting. So we use the DSM-5 in South Africa as psychologists, but we have our own caveats to that because we are in Africa, and in African culture, people have a cultural framework for schizophrenia that's different from a Western one. And it's interesting because, of course, I would consider myself a Westerner, but and I think that the Western way of describing mental illness and schizophrenia is accurate. If I mean, as far as something like that can be accurate, it's accurate. A postmodernist might say, well, the African interpretation is just as valid, and okay, fine. But we take the approach like someone who's schizophrenic might be schizophrenic, or they might be what we call a Sangoma, which is a shaman, a witch doctor.
That's so. Wait, this is the African.
Right, exactly. So we have to make a clinical determination whether this person is schizophrenic or whether this person is a witch doctor.
Okay, so this is something you guys do.
Yeah, and because it's we have to consider the cultural context that we're in, and because, like I said, African culture has a way of framing these types of things that is different. We don't impose this on people unnecessarily, and so we have to then find out: do they have a family history of this? Have they gone for initiation to become this? And they have their own symbology with it. Like they call it, you go to the river, right? When you become initiated, you go to the river, and you have to get into the river, and you have to kill a snake, or you have to drown a snake.
Okay.
And
this is for real?
This is not. You don't for real have to do that.
This is
the symbology is you go to the river and you kill the snake.
Right.
You drown the snake.
Okay, that means you are initiated.
That means, yeah, you're on the way to becoming a Sangoma.
Okay.
All right?
Yeah.
And then they have other way. Then you become an apprentice to a Sangoma, and they teach you how to throw the bones and tell the future, and divine things, and what plant medications to give to people. And so some people have these symptoms.
Yeah.
And they go through that process, and if they're cured through that process, they're a Sangoma. They might then have these symptoms and then not be cured through that process. Then we can say, okay, you're schizophrenic now.
So wait. So the process is the process of initiation.
Yes.
You're talking about. Okay, so this is. Okay, so how does this take place? So let's take an example. Somebody comes to you, or is referred to you, is sent because of something they did, or I don't know, and they display symptoms of schizophrenia. Let's say they hear voices, and they behave in a way that is to you identifiable as potentially schizophrenic. So what do you do from them? Do you ask them if they've been experiencing the initiation?
Generally, actually, what I would look for first is the onset and the themes, maybe, of their hallucinations.
Okay.
Because it's very interesting because it depends on how that person experiences and frames it. Like if they frame it like, I hear my ancestors telling me this and to do this, and that I must heal the sick, or I must do something like this, then I go, okay, maybe there is that. And yeah, I wouldn't do that here, which is the funny thing. I mean, I like I said, I lean to the Western model of looking at this.
Yeah.
And I think it's valid. And I understand the reasons why we do not just impose the Western model on South Africa in every single case. But that also then reveals something interesting about the disease and people itself. Because yes, if you impose the Western model, maybe you have luck with the treatment. If you go the African route, you go a completely different route, and maybe you have luck, and you
Yeah.
cure yourself.
Yeah.
You know,
Yeah.
so if you boil it down to that, then I have to be honest. Yeah, I get it. You know, why wouldn't you then say that's probably valid or possibly valid for a certain group of people?
So, have you met any Sangommas?
Only one actually.
Okay.
Only one.
Could you share about this story?
Um, well, it was just a guy who came in to the hospital, and he had actually been probably in a little bit of a manic episode, what I would have called a manic episode. And when he stabilized on his medication, we did some family investigations. We found out that yes, he was initiated. He became a Sangoma.
So, okay, this it still intrigues me. He was initiated. He went to a river and killed a snake.
Yeah, in their mythological terms, but
In the mythological terms.
yeah,
So what
not
does
like
that mean?
literally killing a snake in a river. That you go to the river where the water is,
Yeah.
where the power.
Okay. So he went to the river literally.
Yeah, and you kill the snake either in your dreams or in a vision or something like this.
Okay. Okay. So whatever. So you actually go to the river and
And you go,
whatever
you
way
meet
you
with
get to
another
kill the snake,
Sangoma.
that's you meet with the Sangoma.
Yeah, because you have to have initiation by someone else.
Okay.
That's already a Sangoma.
Okay. So
They actually call it Utwasa, which is the calling.
Okay.
Yeah.
So is it then? Doesn't it kind of come down to whether a Sangoma got to him first?
Yeah, sometimes it does, actually. Sometimes it could, and that's the thing. That's why I said that I believe that the intellectual tradition of psychotherapy is shamanism. And it's funny how we came full circle to that.
Yeah.
But yeah, the shaman, the medicine man, the Jungian archetype of the wound healer is someone who did kill the snake themselves and comes back with news of how to kill it.
Killing the dragon.
Exactly. And
Yeah.
like I said, it's this is this archetypal thing, right?
Yeah.
And so our Western modality treats it in a certain way, but archaically it was represented in another way. And if you can go through the method of addressing this archaic thing,
Yeah.
this archaic imbalance, killing that snake, and then coming back with the lessons too.
Yes, this is exactly what shamanism sounds like to me. It it distills the psyche into some symbols and dynamics.
Yeah.
And it works with it. It 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 takes it. It manages it in that framework, almost in a way that somebody moves puzzles around or pieces around. This is how I picture it, and so in this mythological but applied way.
Yeah.
This is interesting as hell, because I think as Westerners we tend to get really lost in detail.
Yeah, and that's
at least when benchmarking to this.
Yeah, and that's why I say the framework, the Western framework for understanding it, I do think is helpful.
Yeah.
But it's again important to remember the roots of the tradition.
Man, that's crazy.
Yeah.
Yeah. So I think maybe working with both levels is something that could be complementary.
Definitely, and it actually helped me once with a patient. Interesting guy, but he was arrested for stabbing his mother.
Yeah.
And he was mentally ill. He actually was kind of schizophrenic, but due to brain damage. So he would have the similar symptoms, auditory hallucinations, some delusions, some mood problems, because of some brain damage. Actually, actually we don't know, because he might have been a bit psychotic before the people in his village hit him on the head with a big rock, or it might have been after that he developed these symptoms. But nevertheless, like he would present with these, like, he would say, "I'm the elephant, I'm the great elephant," and then run around like an elephant, and it
Okay.
seemed funny.
Yeah.
But when and then he would say he was another animal, and it was always between an elephant and I can't remember the other one, and it was always between these two animals. And then I was like, okay. And then I noticed that he would switch between tribal identities too. He would say, I'm a Venda warrior."
Mm-hmm.
And then it was another one. I don't think it was a Zulu. It was maybe like a Xhosa.
Yeah.
And he would say, "I'm a Venda warrior." Then he would say, "I'm a Xhosa warrior. I'm a Xhosa king." And then when I like started to delve deeply into his family, it turns out he was kind of this. His mother was a Venda, his father was a Xhosa,
Yeah.
and he never reconciled the two cultures.
Right.
And it turns out that these animals were the tribal symbols
Okay.
of the Venda and Xhosa tribes. The
Yeah.
elephant specifically for the Venda. I can't remember if it was even Xhosa or what animal was associated.
Yeah.
And then I was like, oh, so he's kind of enacting this in a symbolic way, this identity formation. And because of his brain injury and whatever else that was going on, he kind of, this is how it presents itself. And if he was maybe another person without the brain injury, I might have talked to him about his identity. But we couldn't talk about his identity, but we could talk about his animals.
Oh wow. So in what way couldn't you talk about his identity?
Like, I just don't think he had the insight
Mm-hmm.
to go that deep, because he didn't realize that he was sick all the time.
Yeah.
So sometimes he'd be reasonable and a bit more coherent.
Yeah.
Other times he would just descend into these symbolic worlds. And so if I'm sitting with the person, some people might even say, why you do therapy with someone like that? Well, he was in the hospital and so was I. So what else is he supposed to do?
Yeah.
You know? And if we could have those kind of conversations, it might have had some kind of benefit on him. He also used to do this weird thing, like he would quote this specific Bible verse from Revelations all the time. And he would say that at the end of the world, there's these three unclean spirits like frogs that come into the world and cause the destruction. And he says, but what happened was those spirits came into him.
What?
When the person threw the rock at his head,
Oh man.
those three unclean spirits like frogs came into him. So he's saving the world.
Okay.
Because he has these spirits inside him.
Wow.
And as long as they do that, he's okay. As long as they're in him, the world is okay.
Shit.
But he's not. Yeah. And I mean, these were his delusional systems, but obviously he was telling me all of this kind of stuff.
Yes.
And I would try to talk in terms of his symbolism and understand his psyche in terms of his symbolism. But to what end? I mean, he was never going to leave that place, really. He's also too dangerous, violent guy. So, yeah.
That's absolutely incredible. So this guy was basically unable to operate outside of this framework.
No.
Wow.
Yeah, and so he would always be the vendor warrior, the elephant, with the three unclean spirits like frogs that have possessed him and made him so sick. But saved the world. He saved the world. So even in his sickness, his ego finds a way to protect him from, annihilation in a way.
So, and what do we know? Do we know why this happens in people? Why schizophrenia happens?
Yeah, I mean, several reasons. You can talk about it from a neurochemical point of view. You could say schizophrenia, I believe, is related to a deficiency in dopamine. So,
Okay.
so that's one way of looking at it, because the dopamine agonists
Mm-hmm.
increase the level of dopamine and they help with the positive symptoms. I think it is the positive symptoms for sure. I'm not sure about the negative symptoms though. And so you see the medication working on that part of the neurochemistry. You sort of assume that. But then you also look at neuroanatomy, and then it can be like you find some sort of like enlarged areas of the brain. These there are these parts called ventricles, which are basically these caverns that are filled with cerebral spinal fluid.
Yeah.
And the ventricles in people with schizophrenia are slightly enlarged.
Mm-hmm.
So it's like less brain area around certain parts. And it can even degenerate, in that way. But then the real interesting stuff is what Jung used to work with, because there was at some point no real medication, right? And he might have sat with some very psychotic, well, he definitely did. He sat with some very psychotic people, but he might have cured their schizophrenia through just talk therapy and by interpreting the symbolic goings on of their unconscious.
Yeah.
Maybe the content of their hallucinations or their delusions, and really digging deep and trying to understand why did their delusional system organize itself in that way.
So basically, kind of winning at their game.
Yeah.
Yeah.
Entering the madness. And Jung himself went mad for 7 years.
Really?
Yeah, and I believe it's probably because he understood madness so well that he went mad. Like when you can see how people start making certain leaps in their delusional system, under certain conditions, under things that have happened to them. I'll give you another example, actually.
Yeah.
A patient basically who had delusions of persecution. One specific guy was ruining his whole life. And this guy was member of his extended family by marriage. He called him a Angenide Neef. And Angenide means sewn on in Afrikaans, but naing means fucking. So it's like a niece. He's like a nephew who got into the family by fucking someone, basically.
Okay.
Angenide familie.
Yeah.
And anyway, there's delusions of persecution about this guy persisted forever. But if you look into his life, he had this constant rejection from everyone. His father committed suicide, and he took that as his father rejecting him. He grew up in a very punitive home. Like, he had a grandmother who was caring, but the grandfather was very strict and rough and standoffish and would kind of get in his way of a relationship with his grandmother. So he had that very rejecting childhood. And then this other guy entered the family later on in his life and sort of got some of the attention and the love that he craved, and was given something material, I can't remember what it was, by this grandfather. And since then this guy's been out to kill him, and he's poisoned everyone against him, and he's poisoned his whole life. And this man is, so I understood his,
because it ties in.
exactly.
So what makes him a schizophrenic?
In a way, okay, so this is kind of a psychodynamic way of thinking about it.
Yeah.
They would say that his unconscious has built up a persecutory part and split off from the rest of his personality. And so when he's psychotic, he becomes this persecuted person, because the persecutory part is split off and projected into another guy as a way of protecting him from that feeling of rejection. So it can be that I'm not that bad, I'm the persecuted one. The feeling of rejection, that I was bad, people reject me because I'm bad, is projected into this other person, splits off from him, and it's a whole other human being that you're dealing with, like a caged lion, or a hunted, not a caged lion, like a prey animal. someone who's always persecuted.
Yeah.
And it's to protect them from that feeling of rejection, of what is bad about me, that
Yes.
everyone would always reject me.
Yes.
That is projected into someone else.
And I guess I can picture this being a coping mechanism that is quite widespread.
Yeah,
Actually.
exactly.
So I'm still wondering, because for sure I've met people with similar pathologies, and I'm sure you've met others. And also, what is it that made this case schizophrenia? The fact that it was so
Right.
that the split was so unmanageable, or
Yeah,
is
because someone.
that what makes the difference? Because I think we're all prone to mechanisms of hiding behind different aspects of ourselves,
Right.
and trying to compensate with others, and sometimes not having control over the moods and states that we're in.
Yeah, that's a really good question, because you're right. The propensity for our mind to behave in this way in order to defend us from certain unpleasant things is there.
Yeah.
What makes someone else's propensity to do that schizophrenic versus not? I mean, there can be a number of factors. Maybe it's a biological predisposition. Maybe there's some substances that were involved that also increase the likelihood. Let's say if you're really messing around with reality and breaking it down, or I mean, even drinking too heavily can sort of do this. So yeah, it's more like a confluence of factors, but in a way, when someone is delusional, you can see this in a way like pathological extension of a normal way of thinking.
Mm-hmm.
It just goes to the extreme.
So it's I want to say one more thing, because basically almost anybody who is, let's say, an asshole out there is pretty much, it's most likely an asshole as a result of their own suffering and the
Yeah,
way they
probably.
coped with it.
Yeah, probably.
Yeah. So I'm still intrigued by the way we diagnose
Okay.
schizophrenia. So I don't know if it's just me not wrapping my head around it, but it kind of seems to me like we end up diagnosing it when it's no longer manageable. I guess I'm repeating myself.
Well, yeah, I guess from the diagnosis point of view, this is actually where psychology, psychiatry, it does move in what seems to be more of an empirically valid way. So I'm not saying that thinking in terms of like psychodynamics and Jungian ways of doing things, or trying to understand the mind through psychological theory, is not empirically valid, but diagnosis can be directly observed.
Mm-hmm.
And when you break a diagnosis down, you break it into observable behaviors, or at least things that someone can report.
Yeah.
Like you can report that you're hearing voices, that when
Yes.
there's no one around
Yeah.
you, that's a behavior. You
Yeah.
can observe someone's disorganized thinking or their delusional
Yeah.
thinking. You can observe their speech functioning, their mood, and that's really where the diagnosis side of things. So it's basically you follow a list. Does a person have 5 of these symptoms
I see. Because I
in a
guess
certain period of time?
what I was really trying to ask you was for some kind of cutoff point, maybe because I might need to reduce it to something.
Yeah.
what is it? Where do we? Yeah. But I see it's a conjuncture. It's a combination of.
Exactly.
Okay. So that's schizophrenia for you.
Yeah, and Sangommas too.
Sangommas, man. Yeah, maybe.
Sangommas help to protect you from the tsokolos.
Maybe next time we can talk more about that.
Okay, sure.
Yeah. So, I think we can call it a wrap.
Time just flew, man.
All right, man.
Thank you.
Peace out.
Cheers.